Good afternoon, everyone. Good afternoon, sir. Uh, Sudha ma'am is also here. And I think before we start, I would ask Sudha ma'am to introduce sir, and then we will start the topic. I know sir during my post-graduation. He was visiting faculty at Manipal, and we had few interaction. And we have learned clinical history presentation and examination from sir, and I would say it was a tough experience, but it was for us, so we learned a lot, and we were always impressed by uh, uh, his interpretation of the data, that how article is presented, and what actually we should grasp from that as a clinician. So with this very brief introduction, I will ask Sudha ma'am to tell more about sir, and then we will go ahead with our class. Thank you.
Yeah. Good afternoon to all of you. Good afternoon, Sanket, and good afternoon, Dr. Mohan. I welcome all of you to this talk, which is, in my opinion, a very important talk because it's not usually taught in medical colleges how to read a research article. And I did not grow up with research. Dr. Mohan did. Dr. Mohan passed out from AIMS, Delhi, and he was one of their brightest students. And then he's had an interest in research right from the beginning. I know that when he talks to us about his thesis also, he mentioned about how he had to last minute change his thesis and to a completely statistically oriented one. And I think he is somebody who's very comfortable with medical statistics, unlike most of us who, are a little wary of going near it. And in my interactions with him in Manipal, I have learned a lot from him. And I wanted my postgraduates also to understand how to read a research article, because ultimately, after we pass out, that is our source of learning. And if we do not understand how to read it, then we are all fooled right away. So I, I request Dr. Mohan to go ahead with his talk with his brief introduction. Over to you, Mohan.
Sir, you are not audible, sir.
Yeah.
Yes,
right.
sir.
At the outset, I would like to thank Professor Sudha Vidyasagar for those rather elaborate and kind words of introduction. And I thank Sudha Madam and Dr. Sanket Shah for giving me an opportunity to speak on this topic. A chance telephone conversation regarding the critic, appraisal, and appreciation of a research article ended up as this presentation. Actually, Dr. Sudha suggested, why don't you speak? I told her I have my own reservations about the topic because it is not a SS NEET topic, and I don't know how students will receive. But I personally strongly believe that this is a need of the hour, and I thought I'll share my views on this particular topic, that is critic, appraisal, and appreciation of a research article. I have not received any funding for delivering this talk, and I have no conflict of interest to declare. The usual questions with regard to an online presentation: am I audible? Am I visible, perhaps? And are my slides moving? I guess all three are occurring. As Professor Sudha Madam so elegantly told, there is a cold war which goes on between clinicians and statisticians. And while most of us are used to living comfortably with certain level of uncertainty, we intuitively use statistical methods for our daily decision making. Still, there is a certain feel which is distant and maybe which is unclear with regard to clinicians, with regard to statistics. I wanted to talk on a critical review of a publication, more a critic rather than a criticism, because most of the younger physicians, I will restrict to our specialty, that is internal medicine, are broadly guided by the flashcards carried by the medical representatives, people from the industry, and now the iPad flashcards which they show. It is necessary to carefully study a published paper to understand what is the base of how to understand this. So I would like to start off with why physicians need to read a research paper at all. This is David Sackett's classic paper, 1981. It is available free full text online. Such of you who are interested may actually read the whole paper by Sackett. Sackett was the father of evidence-based medicine, and he was the originator of the SRMA's, systematic reviews in meta-analysis, and so on. Among all the 10 causes listed by David Sackett, we can add we can still find them relevant, but we need to add one more current 11th point, that is, we need to critically understand what is evidence. So if we look at the medical knowledge today, there is no controversy. It is expanding explosively. Even with the improvements in access that comes with internet, we have 3G, 4G, 5G, 6G, and we forget the Surg, the social media, and its various avatars, WhatsApp, Twitter, Telegram, Facebook, and so on. It is impossible to keep up with the medical literature. So whatever we need to understand, assimilate, and put into practice, we need to do it in a professional, cost-efficient, time-efficient, meaningful way. I want to state a disclaimer. Usually in any meeting, I like to talk about only my original work. I like to preach what I practice. This talk reflects my personal opinion and my method of training my MD postgraduates. Obviously, there are a variety of other methods and algorithms for doing a critical analysis of a journal article. But the underlying theme for my method or any method is to be systematic. All that glitters is not gold. So not all research is of the same quality or of the same high standards. Just because a paper is published in a journal, be it the New England Journal of Medicine or our street corner university journal or whatever it is, we should not take research at its face value just because it is published. I can show you bloopers in the New England Journal or the Lancet in published articles which have gone unnoticed, no corrigendum presented, and so on. So it's a matter of not accepting everything at the face value. There is a sacred truth in science that there is no sacred truth. Just because something is published, it's not sacred. So I want the students particularly to understand the difference between critic and criticism. In the classical old world bedside teaching, which Professor Sudha is such an expert, and our generation of people, we were the beneficiaries of critique by our teachers. Gradually, critique has melted down to criticism, which is all rampant everywhere. What we want physicians, alert physicians to do is critique of an article, not criticism. Critical review means critique with a Q, not criticism. The words sound same, but they are in fact different. Critique is appraising the strengths, weaknesses, and limitations of a piece of research in order to determine its credibility and or its applicability to what we are practicing. Criticism focuses primarily on the limitations So critic is constructive, criticism is plain attack. So a critic is an impersonal, objective evaluation of the strengths and limitations of a research paper which is being assessed and should not be seen as a disparagement of the researcher's ability. Neither should it be regarded as a jousting match between the researcher and the reviewer. How to begin? How do we start? By looking at the paper. So this again I have taken from Sackett's article. To imagine that nearly 42 years ago he described this is amazing. So whenever you pick up an article, for the current hard or soft copy of the Lancet or the NEJM comes to you, when you look at the table of contents, how do you start? Where do you start? So look at the title. The title interests you. You look at the authors. And the authors seem to have a good track record. It's, you know that they have a good track record or you don't know. Read the abstract or summary. Do you think these are valid and are they useful to you? Then what is your intent? You want to find out whether to use a new diagnostic test on your patients, to learn the clinical course and prognosis of a disorder, to determine the etiology or the causation, or distinguish useful from useless or even harmful therapy. These are a few tenets, caveats with which we contend with. If not, the earlier answers are no, you go on to the next article. Now, assuming our answers are yes, and we are taking up the critique of a research article, how do we go about it? So, whenever you look at an article, I randomly pick this up from the New England Journal. I want you to look at the title. Is it coherent, meaningful, succinct, precise, and focused? Who are the authors? And among other things, look at the bottom. Who is funding the study? Usually, studies funded by pharmaceutical companies, they have a lower evidence rating because there is a conflict of interest. Also look at whether if it is a RCT, I will be focusing more about RCT, not the other types of articles today. So if it is an RCT, is the trial registered? If so, what is the registration number? A trial can be registered anywhere. The trial can be registered in the clinicaltrials.gov website, or in India, the CTRI, Clinical Trials Registry of India, that is maintained by ICMR. But somewhere the study must be registered. Just check whether these data are there or not. So what type of article? Is it a RCT, diagnosis article, prognosis article, treatment article, meta-analysis, and so on? Or it will be obvious from the title and the summary which you read. The three primary areas which you need to assess when you look at a research article are validity, the results, and the applicability. So it is customary to go by a PICO approach, that is the patients, the intervention, the comparator, and outcome. So you should have clarity regarding what is the denominator of the study, what is being assessed, what is being compared to, and what has been the outcome of this study. I picked up one title. So because it is easy to explain the concept of PICO using this title. Are your patients taking their medicine? Validation of a new adherence scale in patients with IBD in comparison with physician perception of adherence. Here, what is P? IBD patients. What is the I? It is the new adherence scale. And what it is compared to? It is compared to the physician perception and pill counts. And what is it predicting, or what is the outcome? Adherence to medication. So whenever you look at a research article, try to get a hang of the PICO. Now, what is validity? Validity you can understand as assessment of methodology of the study. I find the habit of people straight reading the conclusions of the abstract, and they make a one-liner memory aid. Yeah, this is the conclusion of the study. And the least read, most verbose, or most difficult to wade through part of a research article is methodology. It is very much essential for you to understand the methodology, because if the methodology is inappropriate, the case definition is inappropriate, the gold standard for diagnosis is inappropriate, the method of assessment is inappropriate, then the whole conclusions will go for a toss. So it is when postgraduates do a journal club of a research article, they must primarily aim at focusing on the robustness of the methodology, the reliability, the repeatability, the reproducibility, and the robustness of a given methodology. I will briefly touch upon certain aspects related to validity. This paper we published about a decade ago. This was regarding subclinical atherosclerosis in patients with rheumatoid arthritis using the CIMT as a surrogate marker. Not rocket science, nothing spectacular, but something interesting in terms of method. So the idea was to assess which of the patients with rheumatoid arthritis are found to have subclinical atherosclerosis using the CIMT as a surrogate marker. It seems very simple, but I will share with you what had bothered us when we designed this study, because methodology is decided upfront when the study is started, not after the study is done. So the first issue was, what will constitute the method of assessing CIMT? So the same method is used both in cases and controls, using the same machine by the same radiologist who was blinded to the clinical information. Good. Blinded evaluation, standardized measurements, and used by a single operator will minimize bias. So if you see the papers on CIMT, some measure at 3 sites, some measure at 6 sites, some measure at 1 site, and so on. So the most rugged method or reliable method of measuring CIMT was to take the measurements at 6 positions, and the mean of the 6 readings would be used to calculate the CIMT. So this had to be clearly stated at the outset before the study was designed, and the methods, when someone reads it, yes, this is the right way to measure the CIMT. This is an example with something which is easy to follow for the students. And we define the plaque with a certain case definition. Now, we need a cutoff of CIMT. CIMT value more than this is atherosclerosis, less than this is not atherosclerosis. So how do you derive the cutoff? Till such point in time, there, people were either adapting the cutoff defined in guidelines, more than 0.88, more than 0.9. These are the data that are derived from Caucasian population, different ethnic groups from other parts of the world. Some others were taking the 75% of the median or something like that. So there was no clear-cut definition of the cutoff. So we used 2 methods which seemed appropriate. One was the ROC method. ROC is plotting the sensitivity versus 1 minus specificity. I will explain this a little bit more. And the other was taking the 75th percentile value of the CIMT from among the normal control subjects. So how do we derive the cutoff for CIMT? So we derived the cutoff of CIMT between angiographically proven CAD patients and healthy controls. The cutoff was derived from there, and that cutoff was used to define the presence of subclinical atherosclerosis in patients with rheumatoid arthritis. So we need to ask whether the results represent a significant change or improvement from current evidence. When you read a paper, whether these results constitute a significant change or a major improvement from what we already know. No. So this is the ROC. The sensitivity is on the y-axis. The 1 minus specificity is on the x-axis. And these dotted lines, stippled lines, are the 95% confidence bands. And at a cutoff of more than 0.57, CAMT cutoff of more than 0.57, the sensitivity was 84.4 and specificity was 90.6. This was the optimal trade-off between sensitivity and specificity. If we have the cutoff of sensitivity of 1 and 1, that would be an ideal test. But in real life, ideal tests are seldom available. So we had applied the definition of the occurrence of atherosclerosis in patients with RA in normal controls using the ROC curve cutoff and the 75th percentile observed among normal controls. This cutoff was 0.55. So here, two different cutoffs were used to define yes or no atherosclerosis. So these results add value to a randomly chosen mean value or a median value or some such thing in the as a cutoff for defining atherosclerosis. Actually, this is the first and probably the only study from India where a CIMT cutoff was derived from Indian subjects. Then we talk of applicability. Applicability, a study is done somewhere. We need to ask, does this study apply, the findings of this study apply to my patient population? Whether the study results apply to a particular patient I am treating, or is it too great of a leap to apply the findings to my patient? Something they have shown it is useful, not useful, whatever it is. Can I apply in my situation? So I will address some of these questions with regard to the applicability using one of our recent publications which came in the New England Journal of Medicine in March 2023. This was the INTEREST trial. INTEREST trial, as I said, was funded by the India Alliance and the Wellcome Trust. It was registered in the CTRI, Clinical Trials Registry of India. And it is a randomized controlled trial. Intravenous doxycycline versus azithromycin versus both for severe scrub titers. So when you look at this article, was the assignment of patients to treatments randomized? Was the allocation concealed? Were all the patients who entered the trial accounted for at its conclusion? How and why were patients lost to follow-up? There are two aspects related to an RCT. One is treatment allocation, two is treatment concealment. Treatment allocation is randomization. Treatment concealment is blinding. These two are different terms, and one should be very careful in reading about this. We need to randomize to minimize bias. Were the patients and clinicians kept blind to which treatment was being received? The patients, the doctors, the outcome assessors, single blind, double blind, triple blind, and so on are the questions you have to ask. Were the patients analyzed in the respective groups to which they were randomized? Intention to treat, modified intention to treat, or per protocol. So if you look at the first question, where all the patients who entered the trial accounted for at its conclusion, you have to see the consort diagram of the trial. For the benefit of postgraduate students, the PDF of the study was widely made available in the social media, but the published original article PDF, it does not have this figure. So if you want to critically review a paper, first go to the clinical trial registry. Clinical trial registry, take out the original protocol, look at what the author said they will do. Then in the published paper, you see what they actually did, whether both are clearly matching each other or not. So as an offshoot, in the early period of COVID, around May, June 2020, number of studies started appearing in that MedRev. So it was a pre-publication for trials, recovery trial data, remdesivir data first appeared in the MedRev site only. Later on, the papers got published. If any one of you care to compare what was given in the website in June 2020, later on, 1 year later, when the article got published, if you compare it line by line, some very interesting differences, the very interesting contrasts emerge. Please make it a habit to check the original protocol. It is like when we send a postgraduate thesis to the examiner, we also send the protocol. So the thesis copy and the protocol both are given. The examiner, a good examiner, is supposed to go through the protocol to assess what was committed as could be done, and then go through the thesis to understand what has been done. Yes, it is a training in research, but the training should be appropriate. So this diagram, you find it on online supplementary material. So when you are doing a journal club, just don't pick up the article PDF and talk. Often, many things like sample size details, patient treatment allocation, randomization, blinding, all details are available either in supplementary tables and figures online, not in the article due to obviously space constraints. So be little cognizant, read the supplementary material also. Every single paper which you get in every journal article, it is not possible. But during your post-graduation, you are trained to critically assess a manuscript, at least for such articles as an academic exercise. Go through the process at least a couple of times during your training period. So the supplementary table shows this many patients assessed for eligibility. These are excluded. These are the reasons for exclusion. Enrolled and randomized. Following randomization, some patients withdrew consent, etc. Then this number was used in an ITT, and in each group, how many patients were there, what happened to them, and what happened per protocol analysis. A brief word about per protocol and intention to treat or modified intention to treat analysis. See, if you have a study of which was conducted in 100 patients, and each patient had to do some 6 follow-up visits. In this study of 100 patients, let's say 10 died. So if you and 8 of the patients, after being randomized, did not complete the follow-up. So if you remove these 8 patients who did not complete the follow-up, but you take up the 92 patients who completed every step of the study, that is, they had adhered to the protocol, and analyze only them, that is per protocol analysis. However, in real life, since that does not happen, if you consider those who have dropped out as having the worst outcome, so let's say death. So the total deaths are 10. Dropped out, we don't know what happened to them. They are 8. If you take the worst outcome as 10 plus 8, 18, that would be a prototype of an intention to treat analysis. Here they have done a modified ITT and a PP analysis also per protocol. In a good study, the results of both the intention to treat analysis and the per protocol analysis more or less mirror each other. If there are too many dropouts, if there are too many patients who have not completed the study, then the study's evidence rating goes down. Then, where the patient groups similar at the start of the trial, usually the characteristics, baseline characteristics table is provided, and if you look at this table, there is a more or less similar distribution of all the characteristics among all groups of patients. It is, you have to carefully look at all the characteristics considered in the study and the various treatment groups to assess whether the groups, if the groups were lopsided or if the groups were not similar at the start of the study, then the results have to be interpreted with caution. If you look at the primary outcome depicted in this study, this is the upper panel A is a forest plot. The panel to your left side, combination therapy is better. The monotherapy is better, is towards your right side. Clearly, combination versus doxy, combination versus azithromycin is in the combination therapy side. So, if you look at the other composite primary outcome, the combination therapy in this Kaplan-Meier plot emerges as the best option available. So, if you look at death from any cause at day 28, persistent complications at day 7, or persistent fever at day 5, the combination therapy has significant advantages compared with monotherapy. So, when you look at it, the conclusion would be meaningful in that in patients with, what is the denominator? Severe scrub typhus. What is the intervention? A 7-day intravenous course of doxy plus azithromycin was superior to either treatment alone. With regard to what is the outcome? A composite outcome of death, persistent complications, and persistent fever. So, this is the way to objectively look at the results of a RCT. A brief mention, meta-analysis itself is a standalone class by itself, so I would not deal too much into it. But again, the meta-analysis has the origin to the late 80s, early 90s. It is a specific statistical technique to summarize or pool the results of several included studies. Meta-analysis with a E is a reference to several meta-analyses. So, it is a meta-analysis is a study of studies. So, when you look at a meta-analysis, what should you carefully observe with regard to how rugged or how the evidence rating is? For example, I randomly picked up this meta-analysis published in 2023, distribution of lifestyle risk factors among patients with stroke in the Indian setting. It is a systematic review and a meta-analysis. So, what you should carefully think about when you try to understand a meta-analysis, before you contest the conclusions, you should look at the following question. Did the review ask a clear and focused clinical question? Yes. What is the distribution of lifestyle risk factors in patients with stroke in the Indian setting? So, what articles were picked up by the authors who did the meta-analysis? Did the review include the right type of article? RCTs, other articles? Did the included studies address the question, or is the data nested in another study? Were all relevant studies identified? What was the search methodology? What were the databases searched? What were the string or search terms used? How did they track the references? What effort was made to locate unpublished studies non-English studies. Here I want to tell you, I think Professor Sudha will also agree with me. These days, the review of literature in a postgraduate thesis or a dissertation is like a muktavali, a string of pearls. People just go to PubMed, they give a search term, and all the abstracts are listed one below the other. The evidence is not synthesized. The evidence is not understood. The evidence is listed much like a laundry list. There is a need for postgraduate students, at least for the magnum opus in their life, their MD thesis, to actually critically review the published literature. So what search terms were used, what databases were searched, how the references were tracked, how the unpublished data were located. They are equally important to a postgraduate thesis review of literature, and much more important to the systematic review meta-analysis. How was the validity of the included studies appraised? I had spoken about in the earlier slides with regard to what constitutes validity. Validity is the robustness of methodology. In the CIMT example, how in each of the studies CIMT was measured, what was the instrument used, what was the how many sites the measurements were obtained at, how the composite value was defined, and so on. Else, if we simply take it by the face value, the study of something, it is GIGO, garbage in is garbage out. And where assessments of study, the quality of the study, where they reproduce it. Because when students show their research methodology component of the thesis, my students at least, they majorly cry. So they said a CT scan was obtained. Which machine, which make, which model, which manufacturer, which country. They said, is it all required? CT scan is a CT scan, obviously. Obviously, it is not. The 3 R's of research are reliability, repeatability, reproducibility. And the 4th R is robustness. Unless you specify exactly how you did, what you did, it is not possible for anyone else to do what you did. And reproducibility is the soul of evidence-based research in the present era. So they had to, the authors of a meta-analysis must make assessments very critically to assess the reproducibility also. And agreement between the assessors, how was it assessed? Agreement between methods, how was it assessed? And whether the results were combined appropriately, the tests for heterogeneity, etc., they have to be looked into. So this is an example of a critical appraisal which was done. This is that waterfall study which was done by one of my postgraduates in our Wednesday Journal Club. So the study abstract, did the study assess a clearly focused research question? Was the assignment of participants to the interventions randomized? Was the assignments, whether the randomization was appropriate? Were all the participants accounted for? Was the study blinded? This study was open labeled. The patients and the trial staff were aware of the treatment. Naturally, open label studies, evidence rating comes down. Was the study, were the study group similar at the start? Apart from the experimental intervention, did each group receive the same level of care? Were the effects of the intervention reported comprehensively? Was the precision of the estimate of the intervention or treatment effect reported? Here, the trial was terminated at the first interim analysis. Thus, it is underpowered to evaluate the efficacy outcomes definitively. This is a critique on the study. In randomized assessment of aggressive fluid resuscitation as compared with moderate fluid resuscitation for the treatment, the use of aggressive fluid resuscitation led to a higher risk of volume overload. Was the precision of the estimate again properly reported? A word about DSMB. The DSMB stands for Data and Safety Monitoring Board. It is not Shashti Vibhakti. It is not Data Safety Monitoring Board. It is Data and Safety Monitoring Board. And there is the critical appraisal said that the DSMB concluded that much larger sample size would be needed for the trial to show superiority, since the between group differences in the risk of moderately severe or severe acute pancreatitis is small, but this would have exposed many patients to a higher risk of fluid overload. Then come the benefits and experimental intervention vis-a-vis the costs. Can it be applied to our population? And would the experimental intervention provide greater value to people in our care than any of the existing interventions? These are some standardized questions which you can ask regarding most of the RCTs as a starters, as a first steps in critique of an article. I teach my students to assess an article like this, so that later on, if they get swayed by the iPad flashcards shown by a pharmaceutical, they can actually go back to the original articles, take out the article, take out what the clinical trial registry told with regard to the protocol, what the authors actually did, what they reported, read the supplements, and really take a call on their own whether it is worthwhile taking that as evidence which you can use in your real life practice. So, without much ado, I would like to conclude here that critiquing a journal article is an important skill both for academic and private practice physicians. After deciding to read an article, the key is to be systematic. Depending on the study type, look for methodological validity, results, and applicability. I always tell my students, please ask a question. If I were to conduct this study, how would I have done this better? What pitfalls I would avoid? Just because the study is in New England Journal or Lancet, please don't say that everything is rosy with this study. Obviously, nothing is perfect in this world. The idea is to reconcile to the imperfections so that they don't repeat in future research. So, at the end of the day, I think not that I know it well, and yet I know that it is not unknown to me. He or she of us who knows it knows that. He or she knows that it is not unknown to him. Much like statistics, much like research methodology, it looks pretty clear when you read it or when you listen to the videos in the basic course in biomedical research. But then when you close the book, it evaporates. I hope I made sense, and if you have any queries or questions, I think I can take some of them if time is permitted.
Yes, sir. Thank you. Thank you for this discussion. I think I would like to start with one question at least. We have this impression when we get introduced to research methodology, because the pyramid looks like that meta-analysis is at the top, and later on I'm realizing it is not just about meta-analysis title. It's a well-performed RCT which weighs higher. So, sir, how to go further and not to get impressed so much by meta-analysis? Like, what are the ways or what are the red signals we should be looking for?
Meta-analysis is not the holy grail of evidence. While it is a systematically compiled study of studies, it is not end of the road. That's why I kept meta-analysis to the last part of the presentation. A well done RCT, particularly if it is done in the milieu where we are, that would be a very good form of evidence. But what happens is, study conditions are different. Most studies are efficacy studies, because in efficacy study, you rule out the very ill patients, you rule out pregnant mothers, you rule out HIV positive, etc. But in those patients, if you have the same disease, how to treat? What does the guideline? Every guideline goes, it quotes evidence. Evidence is based on RCTs. RCTs often exclude all such patients. So you should keep in mind this caveat. And a well-performed RCT in the environment or in the ethnic situation or the our country of domicile, etc., would be a good evidence for our thing. But for a broad general view of what is the current evidence for practice, still the best of a bad bargain we have is a meta-analysis. But that
Right.
is not the last word.
Right. Sir, few more words about we follow when we are actually writing any publication or something. There are guidelines like for RCT, there's a concert what we follow completely. So while I started reviewing the articles, I started applying that also to this because at least is written as per this guidelines. It makes perfect sense for a reviewer also. The basic rules are followed. So, sir, your comments and guidance regarding that.
Yes, actually, at the outset, when you make the protocol itself, the what you are going to report must be very specifically written. Unfortunately, postgraduate thesis is only training in research. This cohort predominantly is of postgraduate, so I'm not going very deep into that. You have to specify at the protocol stage itself what are the things that are going to be reported. And like for example, you have randomized a person. Your exclusion criteria is a pregnant mother, but you have randomized the person into one arms and that woman gets pregnant. What do you do to that patient? So will you include in analysis? Will you exclude in analysis? That is called trial deviate.
Right.
So these are all caveats which have to be inbuilt into the protocol. And there are several guidelines about, like you have the Prisma guidelines and so many things which are, this is very structured and methodical. If not all, there must be some orderliness in upfront deciding what has to be reported at the protocol stage itself. That's why we should always look at the protocol before we critically review a publication.
Right, sir. And I completely agree that our review of literature, it's a pile of data. But I think what is happening and what I'm saying, though it looks logical, GPT can do it for us.
Yes.
But I think the problem is the insight of information, which is not getting built up for a postgraduate who is going to have a long career in the life. So I think we should not miss that part, that reading the article. I'm not telling the access is there, that's a good part, but the GPT sometime actually is making us handicapped. That's what I'm feeling.
True.
So I use it, but it is making
No,
us.
I have been bombarded by spectacularly meaningfully done literature review with AI, Chat GPT and the variants. But I would tell the student that, look, if you can't do a detailed review of literature since the birth of Lord Rama, you say that as an academic exercise, you will review studies published in last 5 years, studies published in last 3 years, something which is meaningful, which is handleable by you. So you say there's a vast amount of literature, online Medline search with the following keywords resulted in so many thousand articles being retrieved and all. But you say for the purposes of this work, the data during last 1 year, like COVID, you can choose last 6 months. You define the period, go through the motion of doing your own review of literature. To I always make my students make a table. Break down the study, the period of study, the place of study, the setting of the study, the inclusion criteria, the exclusion criteria, the definition used, etc., etc. Once they make one table like that, it may not be thorough, comprehensive, publishable in the best journal. They will get the feel of how it is to be done. So this is what I have been practicing.
And I think last very important question. I know it's more of a specificity or the choice which comes, how to make research interesting for students, because I think it's same with rheumatology. I felt during my UG and PG, it was tough, so it was not interesting, but later on realized that I have to deal with this, and I was failing after MD even to deal those patients, and that's how it invoked the interest in me. But research, still it is there, that once we move to practice, it becomes very difficult. And second thing, that's what we keep seeing, ki people are doing without it, but how to make it even more interesting from that grade, because till it comes to exam, it does not interest a postgraduate.
Absolutely, I concur with you. In fact, Professor Anand Malviya, with whom I trained for a decade, he used to lament upon the lack of an objective definition for several conditions in rheumatology. So he was a very keen researcher. He wanted to, like, if you say TB, you say smear is positive. But if you say fibromyalgia rheumatica, how to? So he used to raise this issue. How to make research interesting is we should develop as teachers a questioning mind. It is said in postgraduate teaching is done by asking questions. So as opposed to undergraduate teaching. So one should the postgraduate says that what is the proportion of valve involvement in patients with rheumatic heart disease in India? Mitral valve is most common. Which study? Who told? Okay, this study. Is it an autopsy study? Is it a echo study? Is it a CAT study? What was the? So by asking this type of questions in the routine bedside ward round, I feel at least some students get interested. What is this person talking? I didn't look at it this way. Let me look at it other. This is what I have been trying, partially successful. Obviously, research is a different paradigm, and we can't accept blindly. Like I learnt about a random zero sphygmomanometer, which is used in research in hypertension. We don't use a random zero sphygmomanometer for routine blood pressure recording. So research is basically efficacy study. It uses certain very critically and very strictly defined conditions. It is different from real life, but the going back from real life regarding what was the question asked in whatever study was done. It is the bedside teaching which should stimulate the mind of the student. We had one patient who had rheumatoid arthritis, who had rheumatic mitral stenosis. So in ward round, Professor Jain Pandey asked us, so what proportion of patients with rheumatoid arthritis have rheumatic mitral stenosis? And what proportion of patients with mitral stenosis have rheumatoid arthritis? And we were all blank. Then he said, you should also look at it with regard to the burden of the rheumatic fever, in which area it is, and the burden of rheumatoid arthritis. That time, the community study with regard to the prevalence of RA was going on in and around Delhi, in Ballabgarh and other areas. So we were all enthusiastic participants. He said, you guys should see how data is gathered, then you will get to know. That's how my boss made research as a priority or area for me. It should start bedside. We should contest bedside with regard to whatever is the answer given. How is it correct? What is the base for the answer? And that will stimulate at least some among the 10 or 100 postgraduate students to pursue looking at data critically.
Thank you. Thank you, sir.
Sanket, a few comments I'd like to make.
Sure,
One is, as usual, Mohan, absolute clarity and absolute brilliance. I've always enjoyed listening to you because there's so much clarity in what you talk. And I agree with Sanket that research is difficult, especially for a postgraduate to access and understand, because we are not taught anything in undergraduation. Suddenly, you are putting the postgraduate in front of the boss and saying, first year you have to choose your thesis topic. He doesn't know what is thesis. He has never seen anything called literature. Because where is an undergraduate reading, literature? We're not exposed to it. So suddenly it's like stepping from a pond into an ocean. There's not even a river. It's an ocean. So suddenly that this thing of inflow of information is kind of overwhelming. And that is one of the reasons why postgraduates are put off by that. And I think I learned a lot. Mine was like adult education. I learned research only after many, many years. Well, as a postgraduate, I had no idea. No, unlike you trained in AIIMS and you had research as part of you. Many of us trained in places where now Manipal is doing very well. And I think your coming for so many years and helping us out did bring up the standards. But right now, like what you showed in your postgraduate analysis, Manipal does research methodology workshop every month, which I used to attend online. And they ask the same questions, was the methodology all right? What were the statistics used? Were the statistics appropriate? Were the conclusions appropriate? And was there a baseline matching? The same questions that you asked, they give them to analyze. And the Manipal postgraduates are trained. But I'm sure Sanket will agree with me that many medical colleges have no concept of, teaching research like that. And that is why people are kind of put off by the number of things. Suddenly you say ROC, suddenly you say intention to treat, or you say logistic regression. Now all these things are put in the postgraduate's mind without much of a base, and that is where it goes wrong. I think in a medical college, at least you must have, like what Dr. Mohan is doing, a kind of a slow kind of learning from the first year, and on the ground learning. See, whatever it is, like what Dr. Mohan says, if you just learn all these terms, intention to treat, you will forget unless you apply. So when you're doing your thesis, to get that methodology right. In fact, when Dr. Mohan used to come to me in Manipal, he used to tell me, your statistical analysis must be written. What are you going to do with your data must be written at the beginning. Are you going to use, chi-square? Are you going to use, regression? What are you going to do with the data? He used to make my postgraduates write it. And I used to find it so difficult because, first of all, terms are unfamiliar. Secondly, we don't know what to apply for what. So that kind of clarity must come right at the beginning for us to be able to come with a protocol, a good methodology. And most of the studies that are published because the methodology is rigorous. It's not the results of the conclusion. It's the methodology. If you have, like what Dr. Mohan showed, you're doing something like a CIMT for a rheumatoid arthritis. He has analyzed 32 patients from Indian population, and he has got a cutoff which is different from the cutoff that we are normally used to. And then he has used it on his population. That's a huge difference, isn't it? That brings out the quality of the paper. And I think that that reasoning must come. I think it is very underemphasized thing in all our education is reasoning. We are not asked, encouraged to question. We are encouraged to mug. We are encouraged to just vomit what comes out. But in real life, both in the care of patients and in research, I think reasoning is very important. Logic is very important. And if you're not taught to think, that is where it goes wrong. And like what he said, that it should be taught as part of the curriculum, and the postgraduate must be made to do that work. In fact, postgraduates used to hate me for insisting on, some kind of rigor, because why are you worried? You just write something and go off. But the point is, most of my postgraduate theses have been published. Why are they published? Because we had a good methodology, we had a good statistics, we had a good reporting, okay, and we learned to report correctly. And he talked about review of literature. The worst part of the PG thesis is the discussion. In a study done in Korea, this was the thing. In a study done in China, this was the thing. In a study done in somewhere else, this was the thing. And I used to say, can you not change at least in the study done? Those 4 words, can you not change? It looks like one repetition kind of thing. And there is no attempt to correlate or, to compare, Dr. Mohan will shout at me if I say correlate. He'll say it's not. He taught me that I should never say correlate. It's a statistical term. But English is English, and that's why I'm saying. But even to write a good discussion, in fact, in Manipal, Sanket, I conducted a competition on writing a discussion for postgraduates. I gave only the data, and I said, all of you write a discussion on this data. And I found that it's so difficult for many people to, it was a very simple study, iron deficiency, anemia, something. And the results are given to you. Methodology results are given to you. Read it, write a discussion. How will you write a discussion for this paper based on the results? I found that that is where you're really testing the postgraduate's reasoning.
Actually, what is missing in discussion in postgraduate thesis is, they say, okay, my results are different from that study. How different? Is it less? Is it more? Then why is it different? That is missing. These two.
So why?
Yeah. So in a study done from Korea, in a studies from Bombay, my results are different. Different means what? It is less or more. And then why? Why has to come in? That rigor has to be enforced in the
attempt to explain.
Yeah.
The attempt to explain must be that there must be a hypothesis that you're talking about. I think all this will come. I see a person who can do an MD medicine is obviously not a dumb guy. He's somebody who has got brains. Just the question of training them. I think if you expose them to more research methodology, they will learn. They have learned so many books. Why can't they learn one more book? It's not impossible. It's just that the way it should be put to them must be better. And I'm sure over time this will get better. And like what Dr. Mohan says, we will be able to analyze a research paper better. Many times I have seen that I saw a paper where there was a control group and an intervention group. Just to get a good intervention group, good results, the control group was treated badly. Can you imagine? That was also done. When you read the methodology, you realize the control group fellows just left like that.
Yeah,
So the intervention
actually,
group,
if you look at the one of the earlier studies of magnesium sulfate in acute MI,
right?
the authors were using the envelopes which were transparent. It's a classic story, historic story in research. The authors would take the envelope and look at it like this against light. If it is showing MagSelf, the less sick patient will be allocated to MagSelf group, and the terribly sick patient will be allocated to other group. What you told. So from then this terminology came. Opaque sealed envelope method terminology emerged after the horror which was created with that particular study. So that is another cause for concern.
Yeah.
Students should have a clarity. What is the denominator? What is the intervention? What we have included? What we have excluded? I tell there is another phenomena which rattles me. At the time we have a thesis protocol approval committee which gives the technical approval. Then there is the ethics committee.
Yeah.
After the ethics committee, then it is a bridge presentation. 2 months before the submission date, it is face presentation. Student will come back. Where were you all these days? I was posted in cardiology, I was posted in village. Now it is posted in district and so on. What did you do? Never the student uses the opportunity to interact on a daily or a weekly basis. Sir, this week I have recruited this patient. This is how I fill my pro forma. Am I right? Am I wrong? I have included this. That type of interaction is required more than for the student. For the younger guides, from associate professor level, people are eligible to be guide because as per NMC, PG teacher is a guide. The younger guide should go after the student. Call them today. What did you include? Show me the pro forma. Pro formas, people are not doing the hard copy pro forma. They're straight away trying. They say I'm putting in Excel. That such research cannot be published. You need a source document. You need a case record form, and you need double data entry, and then the analysis and so on. So I also feel for the benefit of the younger generation, the guide should take some lead. If not the senior most professors, the starting guides should go after the students, sit with them. Look, what did you get? Why did you include this? Convince me that this is satisfied inclusion criteria. I think it must be done like that. There was a question, one comment in the box with regard to the last week NEJM AI review. Yes, AI is a boon, but that's not the end of the road. We still need humans to teach humans how to treat, not machines. One can always take the help of program. I did logistic regression manually using logarithmic tables, which none of you can imagine doing. To do regression took 6 months on a slate and pencil. I did not have so much paper also. I had to do the calculations manually. And now I don't say that is the gold standard method to do. Today, you have to take technology into your fold and use if you are very happy and your institute has bought it for you, you can use SAS, or you are good, you can use R or whatever you want. But the point is, technology will assist human decision making, but it cannot be a replacement. However thrilling and chilling or even killing ChatGPT is, or AI, all this AI for or, it is still the human mind which rules. If you know what to do, the question you ask is answered by AI. It won't ask the question.
Yeah. Thank you, sir. Thank you, ma'am, for the discussion.
Thank you.
Okay.
Thank
See
you,
you
Dr.
then.
Mohan.
Right.
Okay.
I hope I made sense.
Yeah.
Yeah,
I think we
yes,
should
okay.
actually, Sanket, we can ask him to talk on specific statistical tests, like regression
Sure,
and all, he teaches very well.
looking
So
forward.
those kind of things, specific things he will do. He's done
Yeah.
it for us in Manipal.
No
Sure.
issue at all. We learn to share. So anytime which suits you. Only thing is, many of you are owls. I'm a fowl. So what is
We'll
late night
manage.
for you is
We'll
early
manage,
morning.
sir. Yeah.
You
We'll
should
manage.
forgive me on that. Thank you
Sure.
very much. Bye-bye.
Thank you. Thank you.
Okay. Yes.
Thank you, Sanket. Bye.